and then start your speech. You can go live now.
Okay. Good afternoon, doctors. On behalf of Heathrow Healthcare, I, Dr. Prashant Khandeparkar, welcome you to this webinar on PPH management, then and now. Doctor, a brief about Heathrow. At Heathrow, we market products in multiple therapy areas like in gynecology, dermatology, orthopedics, pulmonology, etc. We have very strong R&D support, which is why we have developed products and formulations keeping patient benefit in mind. Our endeavor is always to develop formulations which will improve patient compliance and hopefully ultimately clinical outcome. Doctors, we have developed NSAID patches, rivastigmine patches for better patient compliance. At Frenza, gynecology, obstetrics, and IVF is an important therapy segment for us. We market products for vaginal health like Feminora, Paletra, as you all know. Besides conventional tablets like Didropal, we have recently introduced a lactic acid vaginal film under the name Celeron. Recently, doctors, we have introduced Carbetocin under brand name Carbiac for PPH. PPH, as we all know, is a life-threatening condition and requires intense management. PPH management has undergone change over a period of time. To speak more about PPH prevention with Carbetocin, we have Dr. Mini Bedi with us today. Welcome, Dr. Mini Bedi.
Thank
Madam
you.
is Associate Professor, Department of Obstetrics and Gynecology, Adesh Institute of Medical Sciences and Research, Bhatinda. Madam is Founder Secretary, Bhatinda Menopause Society, member of Oxy AMA-SI, FMAS 2018 and MNAMS 2021. Madam has various publications in both national and international journals of repute, and Dr. Bedi is reviewer to various journals, international journals. Madam has special interest in fetal medicine and high-risk pregnancy. Welcome, Dr. Bedi, once again, all yours to share experience about Carbetocin and management of PPH. Welcome.
Thank you so much, Dr. Prashant, for so much kind words. Well, what I feel about Carbetocin is, it will not be good if I do not talk of Carbetocin without talking about PPH first. So let me talk a word about PPH as well. So what is actually PPH? The postpartum hemorrhage, it is actually a dreaded complication. As a gynecologist, we all dread having a patient with PPH. Anyhow, so postpartum hemorrhage is defined as a cumulative blood loss. If it is more than 500 ml for a normal vaginal delivery, we take it to be PPH. Or if it is more than 1000 ml for a cesarean delivery, we take it to be PPH. In other words, actually, any amount of blood loss within the first 24 hours after birth, which leads to an increase in the pulse rate or a fall in the blood pressure for a patient, actually changing her hemodynamics, will be considered as PPH. So we have two types of postpartum hemorrhage, that is primary and secondary. Primary would be which occurs within first 24 hours of delivery, and secondary would be from 24 hours se leke anything till 12 weeks of delivery. We all know about the causes of PPH. We always talk of it like 4 T's. T's means one is for tone, tissue, trauma, and thrombin. So tone is the abnormality in the uterine contractions. Tissue, that means some retained products of conception are there inside the uterus, and that is causing an increased amount of blood loss. Trauma means any injury to the genital tract. It may be the uterus, it may be the cervix, it may be the vagina, it may be the perineum, anywhere that causes an excess blood loss is a cause of PPH. And thrombin pertains to the abnormality of coagulation. So if we consider it carefully, uterine atony is the most common cause of PPH, which accounts for around 70%. 70% cases of PPH, followed by a trauma or a retained products of conception or a coagulopathy, which is very rare, even less than 1%. We all know about the active management of third stage of labor. Ever since 2013 guidelines of Oxy, we have been following active management of third stage of labor. That is the controlled cord traction, prophylactic use of uterotonic drugs immediately after the delivery of the baby, which usually is oxytocin, IM or IV, however they give, cord clamping and cutting and controlled cord traction of the umbilical cord, and the uterine massage. So in this, we take the advantage of the first uterine contraction and try to control the bleeding as soon as possible. So these steps excite a powerful uterine contraction, aid in early placental separation, and they minimize the blood loss and duration of third stage of labor, which is actually just 5 minutes. So if we talk of some uterotonic drugs, that is those drugs which can increase the tone of the uterus, we have very easily available oxytocin, which the world has been knowing it for long. And now the recent analog for it, which is a carbetocin. So these are actually posterior pituitary hormones and their analogs, oxytocin and carbetocin. Till now, oxytocin has been and it has remained the gold standard for the treatment and prevention of PPH. The others are ergot alkaloids, that is ergotamine and methylergometrin. Then we have prostaglandin analogs like PGE2 or the dinoprostone gel, the misoprostol and carboprost, which are very potent uterotonics. So if we talk of oxytocin, oxytocin is actually a nanopeptide, which is synthesized in the supraoptic and the periventricular nuclei of the hypothalamus. It is transported from the hypothalamus to the posterior pituitary, where it is stored for some time and then eventually released into the circulation. As we all know, oxytocin acts through the receptors of oxytocin, which are there in various organs, specifically the uterus, and voltage-mediated calcium channels to initiate strong myometrial contractions. It stimulates amniotic and decidual prostaglandin productions as well. So bound to the intracellular calcium, it is eventually mobilized from the sarcoplasmic reticulum to activate the contractile proteins. So the uterine contractions are physiological as well. That is causing the fundal contractions with the relaxation of the cervix. That is the first action of oxytocin, which we usually start at the onset of labor. But the problem is that oxytocin is short acting. It has a half-life of approximately only 3 to 4 minutes. The duration of action lasts for approximately 20 minutes, and it must be administered as a continuous IV infusion to attain a sustained uterotonic activity, if especially we are talking of a case like PPH. There has to be a cause of this prolonged use of oxytocin. The cause is that there is something known as receptor desensitization. That means that oxytocin used for induction of labor or augmentation of labor, that means you have been already giving oxytocin for a long time previously, before you needed the uterine contraction to control PPH. That was in the time of labor, you were using oxytocin. So it may desensitize the oxytocin receptors and thereby impair its post-delivery effect on the uterine contractility. Other adverse effects, though rare but can occur, they are arrhythmias, nausea, vomiting, uterine hyperstimulation, especially when those, usually for those practitioners who use oxytocin for the labor induction and augmentation, they must have come across these. Sometimes they may have uterine hyperstimulation, which is often associated with abnormal fetal heart rate patterns, which we usually take it up as fetal distress. We have to stop oxytocin and look for the other fetal heart rates. Otherwise, you may have to take her up a cesarean section. A very characteristic adverse effect of oxytocin is water intoxication. Because of its antidiuretic action, it can cause water intoxication in the body. Then hypotension. A single IV bolus injection, however, doesn't cause severe hypotension, but repeated bolus injections can cause hypotension, especially if the patient is hypovolemic or in patients of heart disease. Then it can even cause uterine rupture due to violent uterine contractions. So what is the need of the hour? We actually need a longer acting uterotonic drug. Of course, it should be a single dose phenomena. It should be devoid of repeated administration. That means there should be an ease of giving just one-time administration. Then superior or similar efficacy to oxytocin. If not superior, at least a similar efficacy to oxytocin. It should be devoid of the receptor desensitization, which is the major problem with oxytocin. And of course, it should have a superior side effect profile over oxytocin. So finally, we have carbetocin. Carbetocin is oxytocin in which The hydrogen on the phenolic hydroxy group is substituted by the methyl group. If we talk of it here, it is changed by the methyl group. The amino group on the cysteine residue is substituted by the hydrogen, and the sulfur of the cysteine residue is replaced by a methylene group. So this is more about chemistry. Perhaps we may be more worried about the physiological effect on the body. So carbetocin is a long-acting synthetic agonist analog of the human oxytocin with anti-hemorrhagic and uterotonic activities. Upon administration, carbetocin targets, it binds to and activates the peripheral oxytocin receptors that are present on the smooth musculature of the uterus. This causes uterine contractions and prevents excessive bleeding after childbirth. Wonderfully important for a new drug is that half-life of carbetocin is 40 minutes, which is around 10 folds higher than that of oxytocin. The uterine contractions occur in less than 2 minutes, just after the administration of oxytocin. How do we give oxytocin? It is around IV administration of an optimal dose of around 100 micrograms. It was also found that single IV bolus injection, intravenous bolus injection of carbetocin was at least effective as 16 hours of continuous oxytocin infusion. Carbetocin doesn't need repeated administration. So these are actually various advantages of stronger, maybe analog of oxytocin, which it has over oxytocin itself. That means a long duration of action, half-life is more, the ease of administration because it is longer duration of action. So perhaps we need to give it only once and it can work for hours together. So it doesn't need repeated administration. So if we talk of the WHO guidelines on the use of uterotonics in the prevention of postpartum hemorrhage, it shows that when the context was efficacy and safety of uterotonic drugs for PPH prevention, the recommendation said just next to oxytocin we had carbetocin, and then the other analogs or other drugs which can be used for prevention of PPH, like misoprostol or ergometrin or methylergometrin, and symptometrin, which is a combination of both oxytocin and ergometrin. So if we read point number 1.2 here, it says that the use of carbetocin 100 micrograms IM or IV, it is recommended for the prevention of PPH for all births in context where its cost is comparable to the other effective uterotonic drugs. The only thing, if we talk of in the Indian scenario, is the cost of carbetocin. Perhaps those who do not want to use, or those who are maybe having a debate against carbetocin, would talk of only this point. Other than that, carbetocin is a wonderful drug. So the results, let me talk of the main guidelines. The carbetocin is recommended by WHO as an effective uterotonic drug in its 2018 guidelines itself. And at the same time, carboprost is not recommended by WHO since they are associated with increased risk of diarrhea and vomiting. And I have seen at many places that this practice is very common. In case of treatment of PPH, yes, there are people who use carbetocin very commonly because it is easily available, it is heat stable and all such stuff. But then for the prevention of PPH, if we talk, this is not a very good drug. Perhaps it should not be our first choice. So carbetocin is proved to be superior to oxytocin and other uterotonic agents with respect to prevention of PPH, estimated blood loss after delivery, need of additional uterotonic drugs. We would have seen sometimes after giving oxytocin for some time, if a patient has gone into PPH, we see that most of the times we need an additional drug. Some people use methergin, some people use misoprostol, as the case may be, or as maybe the availability, frankly speaking. But then it has been seen that after carbetocin, the need of additional utrotonic drug has been less. So, of course, there's decrease in the hemoglobin and hematocrit levels, less decrease in the hemoglobin and hematocrit levels if we use carbetocin, and the need of blood transfusion. So, this was a wonderful drug. We all know that. The champion trial, it was carbetocin hemorrhage prevention trial, which was recently known as WHO champion trial. So this trial was carried out by the WHO for carbetocin versus oxytocin across 23 centers in 10 countries, including India, including a setup like India. So carbetocin was proved to be non-inferior to oxytocin, with an extra added advantage that there was an ease of single dose administration. So this is another study which actually was done upon carbetocin versus oxytocin in prevention of atonic postpartum hemorrhage. And the conclusion of the study was that in comparison with oxytocin, carbetocin was found to have a better utrotonic effect in the management of PPH due to uterine atony after delivery, either vaginal or cesarean, as it decreases the incidence of occurrence of PPH and postpartum blood loss. So this is another study regarding adverse effects of carbetocin versus oxytocin in the prevention of PPH after cesarean section. So these people concluded that carbetocin can reduce the need of additional utrotonic for PPH, the need of blood loss, and the amount of blood loss, and the need of blood transfusions. So the only thing, any drug, my pharmacology professor used to say that any drug will be called a drug if it has some indications and it has some contraindications. There is no drug in pharmacology which doesn't have a side effect. And so there are a few limitations to the use of any drug. So if we talk of contraindications, as in the case of carbetocin, the contraindications include inappropriate timing during labor and delivery, such as before delivery, it should never be used, or to induce labor. Like we have seen, oxytocin can be used for inducing labor, for augmentation of labor, and many other purposes as well. But, and of course, to prevent PPH. But in the case of carbetocin, we take it specifically only for controlling PPH. It is not used before the delivery of the fetus. It is not to be used for induction of labor. Then there are hepatic and renal diseases in such patients who suffer from hepatic and renal problems. They should also not have carbetocin. Then carbetocin can actually cause serious arrhythmias in the heart, and so severe cardiovascular disorder patients should also not be given carbetocin. We have to be careful in patients with preeclampsia and eclampsia. Although recently, till date, these two conditions have been labeled under contraindications, but then there are studies going on which are taking such patients into considerations under controlled environment. And they are trying to see what are the cardiovascular changes such a drug can cause in preeclampsia and eclampsia patients. And then it will be finalized later on. So till then, we will consider these under contraindications for use of carbetocin and known epileptic patients. So that is all from my side. Dr. Prashant.
One minute. Thank you so much, madam. It was a lovely session. A few questions have come, One is that, should carbetocin be used only in prophylaxis of PPH, or use it in normal delivery also?
Prophylaxis means, Dr. Prashant, we are trying to prevent something.
Absolutely.
Something before anything has happened, frankly speaking. So before PPH has already occurred, we would like to prevent a PPH.
Absolutely.
So immediately after the delivery of the fetus, we can give carbetocin, yes. we are trying to prevent a PPH. Of course, a PPH has occurred, then
Hmm.
you are definitely supposed to give
I mean,
carbetocin.
yes,
But
yes,
prophylaxis
yes.
also, yes, you can give it.
God bless, it should not happen. PPH, we know what is PPH.
Absolutely. It should never happen to
And
anybody.
you know, it's like this, expect the unexpected. You don't know in which patient it will come when.
Actually, OBS is
Yeah,
very
yeah,
unpredictable. You
yeah,
cannot, you
yeah,
can
yeah.
never say constipation will go into
Absolutely,
PPH and constipation will
absolutely.
come out without
And
any
once they go in
complications.
PPH, my God, the entire hospital is in
Oh,
tremors.
everybody is running with their heads on the tip.
Another question, there are a few questions, you know. One is why this carbetocin is actually smarter, if you can use in today's mobile term. Is it because of structure, I suppose, or
Perhaps the chemical structure is good
chemical
enough.
structure?
Yes.
Yeah, yeah,
So that is why I told you about the chemistry and all,
yeah,
although it is less relevant for the
correct.
people like doctors. But then yes, we need to know that
Yes,
there are a
yes.
few changes in the
Correct.
chemical
Chemical
formula.
structure, which has made
That
that
is why,
difference.
that is why it is so stable and it is good.
Can we give carbetocin prophylactically in every delivery to prevent PPH? The ideal answer is yes, of course. You know, we don't know when you'll expect it. And which are the patients who are more likely to get PPH? Like patients with uterine atony, we say, but imagine uterine atony. Which are the patients who are most likely to get? Is it multiple gestation, or is it fibroids, or is it prolonged labor?
Absolutely. We need to identify the patients beforehand in order to prevent PPH rather than treat it. You know?
Absolutely.
I always tell my PGs also, it is better to anticipate the problem
Correct.
rather than treat the problem. So unless we know the factors which patients will land up in PPH, we will never be prepared for controlling.
That's correct. That's
there
correct.
are a few patients who have over distended uterus. They are
multiple
prone
gestation
to go for like multiple gestation,
Yes, yes.
like polyhydramnios, like
Yes.
patients with huge fibroids.
Correct.
Usually the higher end fibroids, the lower end fibroids may not matter much. But then there are a few patients like who have been on oxytocin infusion during labor,
Prolonged labor, like
prolonged labor. Then certain referred cases who have been hitting and trying the labor for a very long time.
Absolutely.
And then finally they land up to you. So such patients, you should be actually prepared that you may find a PPH.
Correct.
There are a few medical conditions like patients with anemia, patients like already
even patients with
anemic,
anemia, they can land.
any hemodynamically unstable patient,
Correct.
they will
Blood,
have more of
yes.
flow, and
Correct,
which will actually lead to a PPH for them. Like
anemia,
the
even
amount of blood loss,
loss, yes, little
the
loss could
amount of blood
matter.
loss for them will be dangerous.
Yeah,
It may not be
correct,
500 ml for them, but then the
absolutely.
200 ml will also be dangerous to them.
500 ml is just a number, but then it depends on the basic.
Right. So we have to be prepared
correct.
for such patients.
Right? Is there something called as oxytocin failure or oxytocin fatigue? Maybe it happens in prolonged labor, maybe it happens in prolonged use.
Especially for certain
how
conditions
common
in
it
which
is?
it is not like very common, but then yes, you find such patients, especially where you cannot give other drugs to induce a labor or to augment a labor. You start using oxytocin. It is a safer drug for induction as well as augmentation. So for those patients whom in oxytocin already has been used for a very long time during labor for 5 to 10 hours, it actually causes a fatigue. It causes desensitization of the
Then of course even carbetocin will not work.
Yes, and so that is why other measures like massage
Misoprostol,
and perhaps you may have to use everything.
Everything. I mean, it's not 1, 2, 3. It's 1, 2, 1, 3. You know,
it is 1, 2, 3 all.
Absolutely, absolutely.
Right.
And another question is, do you feel that carbetocin force of contraction with carbetocin is better as compared to oxytocin? Is more intense?
Yes, it
the
is.
Frequency and force.
It is definitely. The frequency is good enough. It stays for very long. That is the best part of carbetocin.
With just one injection.
Yeah, just one injection. It stays for long. The amount of uterine contraction it gives to the uterus, it stays for long. That is the best part.
That's
that
the most
actually
important.
challenges the use of oxytocin in normal delivery.
Yeah. And suppose if someone has used oxytocin in the second stage for dilatation, they can very well use carbetocin for PPH.
Yeah. They can use. There is nothing like that they will interact. Nothing like that. Oxytocin is a very short-lived drug. It will go off.
Correct. The worst part is, it requires infusion. I mean, in deep interiors of India, IV infusion could be a challenge.
Yes, we
Do
have
you think
seen
cold
patients.
challenge? Yes, cold challenge could be a challenge.
It is, of course.
In Mumbai also, it is. There are a lot of power outage and etc. is happening.
We stay in Punjab in a very hot climate. And yes, cold chain, of course, plays a very important role.
Yeah. It does.
Sometimes
It
we have
does.
seen we need to change oxytocin vials again and again so that it
Correct.
starts acting.
I mean, you people do it, but at many places they may not be doing it also.
They
You
may
don't
not be
know.
doing it.
Yes.
True,
Yes.
true.
No, this question is entirely mine. With all these pluses, I mean, you
Yeah.
actually gave answer, which is the cost. Why is not Carbetocin climbed to number 1 position, which you should have?
That is
Possibly.
the only answer you just gave.
I got I said this anything else.
Even if we agree or not, India is actually still a poor resource.
Yeah.
So whatever
I
is
mean,
available to
practical.
the government, it gives
Correct,
free of
correct.
cost. You can give it to
Absolutely.
patients.
No, I mean, yeah.
So we are waiting perhaps for the time the government proclaims it and it gives free of cost.
That
to
is
each and every
beautiful. That would be wonderful. What is your choice in case Oxytocin or Carbetocin doesn't work? Which one you go for?
Dr.
Prostaglandin or
Prashant, it is a
prostaglandin?
nice drug, yes.
Better than methergine also.
Misoprostol, yes. Because methergine is contraindicated at so many other places as well.
Even
like
hypertension,
diabetes and
this, that,
hypertension and everything. Sometimes the patient comes and delivers. You don't even come to know the previous status. What was it?
Correct.
So before taking the problem, it is better to be on the safer side.
Safe.
So misoprostol is better. I personally feel that.
I think that is all the questions that we have received. Anything more, we'll definitely come back to you. It was wonderful, madam.
Sure. In fact, I would like to share that we have recently taken up a thesis on oxytocin versus carbetocin again at our college. And we are doing it. And till now, like whatever cases we have done, we are actually finding carbetocin really nice.
Lovely.
In order to say that, yes, this should be given to the public at large.
Absolutely. And possibly the only hindrance is the cost that you mentioned.
Of course. Possibly the hindrance is only for cost. Nothing else. In any case, carbetocin is far better than the analog.
And sometimes for PPH, I suppose someone should, not worry really about the cost and think patients. Yes.
In fact, those were indicated, were actually needed.
Uterine
will always
atony,
say a yes. Anybody will say a yes. No doubt.
Right. Thank you so much, madam. Thank you. It was a wonderful session. Thank you so much.
Same here. I love to be with you. Thank you so much.
Thank you. So wish you a pleasant evening. Thank you so much.
Yeah. The same.